Good afternoon. Well, for people on the East Coast, good morning for West Coast. This is Bill Petersohn from MCT. We're going to be starting shortly. I just want to give any people that are running just a little bit more time. So we'll just give it another minute or two before we start. So hang tight, please. Okay, so again, welcome. Welcome to the MCT webinar on health benefits. My name is Bill Petersohn, Managing Director at MCT. And this webinar, the reason for the webinar is to basically show, one thing we do at MCT is we help clients, make money hedging and help cut costs in areas. We've shown outsourcing and other things, and this is actually another benefit that at MCT, what we ended up doing is basically got out of that typical carrier model and went into the partial self-insuring model, and seen some really good benefits from this that are going to be significant cost saves. So the purpose of this is to bring this information to you, get it in your hands, see what you like, what you don't like, ask a lot of questions. Unfortunately, because it's a webinar, you can type your questions in, but we'd like to get through the webinar and then leave it open for all the Q&A, because this will really be, there could be a lot of good Q&A going on with this. It's kind of like when we talked to you about hedging for the first time and there's Q&A, you have to kind of be in the same room. Unfortunately, we're on a webinar. So just bear with that part. But with me, I want to introduce two folks, Brian Husowitz, who is the CEO of Andus Health Benefits. He runs, it's a consulting firm that MCT has used and uses to help us go down this path. The other person that's in the room with me is Mike Brooks from Vested Insurance. Mike is a broker with all types of insurance, so he's got a lot of experience with clients that, maybe like yourselves, where someone like Mike would come in and introduce you to this carrier insurance model where, most people are, where you just get that generic benefit with whether it's Blue Cross or U.S. Healthcare or Cigna, and everything's done with them, and then you get those high increases every year. So Mike's a broker who has been in the old model and now has clients in the new model. So he's here for some, background purposes to show what it's like on that end. So that's the introduction. Those are the folks that are in the room that we're going to, go over, that we're going to discuss this with. But essentially what I want to talk about is what Andus has done for MCT is kind of what MCT does for clients in hedging. They've taken us out of that best effort world where we get that lousy best effort price because we don't know any better. And they've lift up the hood in insurance and introduce us to the way the big boys do it. Just like in hedging where, we lift up the hood and say, hey, you can compete in this whole bid tape arena. All you have to do is a few things. You have to manage the risk by hedging. You have to manage pipeline. and things like that. Andus did that for MCT. They lifted up the hood. For me, it's eye-opening because I'm the person that brought Andus in and took MCT down this path. Also, I'm a very heavy user, as you'll find out, of health insurance. But the interesting thing is, what is their model is kind of like MCT. They lift up the hood, they tell you how it works behind the scenes, and more importantly, conceptually, the way I see it is, we used to have 1 year we had U.S. healthcare, then we had a huge increase and we switched to Blue Cross, and then we had an increase and we went to Cigna, and then we switched back, and and we look at those carriers where they are the network. That's who you go to, the Blue Cross network. They're also the insurer, and they're also manage the whole third party, the benefits of payments and stuff. What Andus does is says, hey, that's the best effort world. The mandatory world is they lift up the hood and say, you know what we do is we're going to find one of these companies to be the network. So at MCT, Cigna is our network. We rent the network from Cigna. We use their negotiated prices with hospitals and doctors and whatnot. And so now we deal directly with Cigna for the network. As far as the billings and how that goes back and forth, that's a third-party administrator that specializes in this stuff, because companies like GE and GMAC, they self-insure, but they need someone to manage those benefits, that, payments going in and out and reviewing things. So we have a network we rent. We have a third-party administrator, and then we have a stop-loss carrier, the actual insurer behind the scenes. And Andus introduces us to all those and helps set it all up. So that's how we are able to, control our costs, control our destiny, if you will. So that's kind of a high level of sort of what happened with MCT. What I'd like to do, though, is turn this over to Brian, who is the CEO of Andus, and we'll walk through the slides and let him explain, how the model works, what happens, and why. And then we can go back and we can talk about some of MCT experiences, because we've been doing this for 2 years. And we're going to talk about Mike Brooks and his clients' experience as well. So with that, I want to turn it over to Brian and let him talk about, Andus and the healthcare model.
Great. I appreciate you guys' time. Bill's going to hold up a sign to tell me to speak slowly during this, so because I have a tendency to get very excited about this product and about what we do, so I tend to talk fast. So hopefully I can talk slowly here. But I appreciate your time, and I'll try to cover some material pretty quickly here. First of all, the first starting point is what Andus does, and if you want to go down the slides of the carrier broker model, right here's a perfect start. So the model that most people are in is what I call a carrier broker model, and it is where the carrier dictates everything to the client, and the broker works for the carrier. Now, the problem with that model is simply this. Why do we allow Blue Cross Blue Shield, Cigna, United Healthcare, Aetna, any carrier you want to mention? You can get into the regional carriers as well in California and DC or anything, but why do we allow those carriers to dictate what we offer as employers? If you understand what the carrier really is, which Bill already alluded to, the carrier, such as Independence Blue Cross in Philadelphia or Care First or any Blue Cross or United Healthcare or Aetna, is really just a claims payer and network administrator. What they do is they'll go to a hospital and they'll say, you know what, you can charge $1, but I'll only pay you 45 cents on that dollar for every claim. And you'll take that reimbursement because you'll get paid in full. And my only agreement is that you won't balance bill my individual. And the hospital takes that agreement and says, great, I'll take it, right? So that's their role. And then to make sure those claims are paid. Somewhere along the way, we allowed them to call themselves insurance carriers. And we started buying health benefits like an insurance product, like we buy Geico insurance or car insurance. Well, true insurance products are a transfer risk. I get buying that the way you buy. If you're going to buy auto insurance and you hit a tree every day, you're going to want a low deductible and you're going to pay a high premium. If you want to take a risk that you're a good driver, you'll go in and say, I want a high deductible, and get your price that way. That's a true purchase of insurance. In the health benefit world, though, as I said, with the carrier dictating the process, it doesn't work that way. So the carrier comes into you and says, here's your plan design, okay, that you're going to have to offer. Here's your rate. And basically, I'm going to give you 30, 60, maybe 90 days to make a decision on what you're going to offer, right? Well, if you understand that the carrier is really just a network administrator, why are we allowing them to do that? So what we basically do is say, as Bill has referred to, we take you under the hood and say, okay, if you want their network because we appreciate their rate of payment or we appreciate the 45 cents on the dollar rather than retail, let's have their network. But let's determine what we want to offer as benefits, and let's determine how much insurance we want to buy. So how does that work? Well, in my world, benefits design, the plan design, is really just deciding how much do you want a member to pay when they access care. And there's certain guidelines around it under ERISA and the ACC. But if I decide I want a copay on my primary care physician to be $10, that's fine. That means if it's a $50 charge, I as the employer are paying $40 and my member's paying $10. Okay, that's a decision I make. That's plan design. Well, that should be a starting point of where you should be able to design the plan you want. So how does it work in the carrier broker model? It doesn't work that way. You get a renewal 60 days before. They tell you it's 20%. And the carrier then says, why don't you change your plan design? If you raise your deductible to $1,000, I'll cut your premium by 10%. Okay? And you think that makes sense, and you say, okay, I don't really want to do that, but I'll take advantage of this premium savings. Well, the problem with that is very simply this. First of all, who's understanding what that real cost is? You have nobody, the broker doesn't, because the broker works for the carrier. The carrier is giving you a rate decrease, but how do you know it really costs that much? Well, let's look at that scenario. If I change my plan design because 2 people were my highest users and the other 100 did not use the plan at all, if I raise my hospital deductible by $1,000, I'm really only saving $2,000. But the carrier is telling me I'm saving a certain percentage. The problem is I've just decimated the plan for 100 people to theoretically save money, and in reality, it's a false number. At the end of that year, that carrier comes back and raises the renewal. So what we get to with this carrier broker model is we want you to stop buying your benefits as though like you buy insurance. We want you to start understanding, buy each component properly. And Bill kind of laid it out for you. You want your network, you buy your network. You want your plan design, design the plan design you want. And here's the best part that Michael attested when he talks about it. The clients that we have come on board design the plan they want, and they never change it. If they ever change it, it's because they have the data that says, hey, I should change my emergency utilization, my emergency room copay, because people are going there rather than going to the doctor's office, but the data would drive that. It's not the carrier driving that through a broker. So in the end, our whole model is built upon buying the components you want to buy and designing the plan you want. One of those most important parts is not looking at the benefits plan as though it's an insurance product. And so there is an insurance component, as Bill referred to, which is your stop loss. But the stop loss is really just to prevent the volatility. So when I started this business, I worked for Fortune 500 and 10,000 life companies. The difference between the way they buy insurance and the way a smaller market buys insurance is they buy very little insurance. Volatility is not their worst enemy. They're pretty predictable. They know that they're supposed to have 1,000 claimants that run at X, and they're supposed to have 10,000 healthy claimants who are going to subsidize them. Okay, so they pretty much stay stable. Well, a smaller group, volatility is the worst enemy. Thus, what you need to buy is insurance to protect against that volatility. Well, we can help you determine what level of insurance you need to buy to protect you and assess to your risk profile.
So here's where I say this is just like MCT, because you want to deliver mandatory, but the volatility you can't handle. We can't handle the volatility in the short term. If we were all Warren Buffett, we could. We have the cash flow. So we take out hedges as insurance to manage the volatility. Same thing that Brian's talking about which is what I thought was really interesting about the whole model. It's just like the hedging model. We take out insurance, stop loss insurance, to limit that volatility, to limit that risk, and then I'll let Brian jump back in on that to talk about the stop loss.
Yeah. So stop loss is so in your fully insured products that many of you probably experience, or if you're already partially self-insured, you're buying it. There's insurance to prevent against the high cost claims. So you're not worried about a person running up $200 in claims. You paid it $200, it's fine. You're worried about $1 million claim. So if you're a 50 life employer, 50 employees on your plan, if you had $1 million claim, that could completely destroy your cash flow in your business. So you buy insurance to hedge that risk, right? So in a scenario of a 50 life case, you might buy insurance that says at $30,000, I will pay up to $30,000 an individual, and at $30,000, the insurance carrier will take unlimited risk. So if I have $1 million claim, that insurance carrier will pay out 970 grand. I only have $30,000 risk. I will pay my premium for that insurance. Well, that's the way we buy it, and what you're buying is on a year-to-year basis. So when you buy that $30,000 policy, you're buying what the insurance carrier rates and says, you know what, you're a 50 life case, I expect to pay out $50,000 in losses. The carrier expects you to have an $80,000 claim every year. They don't know if you will, but the stats tell them that. So they'll charge a 50% margin, and let's say they'll charge you $150,000 for that insurance level, okay? They expect to pay half of it out and the rest is their margin. Well, theoretically, they could pay out $1 million and lose big on you, okay? Now, is that your problem? In my world, it's not. In my world, you bought that policy, you transferred the risk for a year, that insurance carrier pays out $1 million, so what? At the end of the year, when they come back and say, I want my money back, you say, no, I clearly can see, because I have all the data, I clearly can see you paid $970,000. However, you're an A-rated carrier, first of all. There's about 26 in the country, AM best rated. So I know you have thousands of clients. You win on some, lose on some. So this one client is not important to you. But number two, do you think that claim is going to repeat? That was let's say, for example, that $1 million claim was, I've seen weird stuff. Somebody went on a tropical vacation and got a parasite. And it was $1 million in claims, but it's gone. It's been treated. And it was treated in a 2-month period. Paid $1 million in claims. Insurance carrier paid $970,000 in this model. The employer paid $30,000. That's not a repeating situation. So the insurance carrier has a choice. They can either try to get their money back, or they can say, you're right, I'll go back to taking my margins on this case for the next 10 years. I know statistically that can't repeat. I know that I'm probably going to pay $80,000 out again next year, so I'll charge $150,000 premium. Now, in a perfect world, that's how it works. It doesn't always work that way. In our world, maybe we have to go to another A-rated carrier and say, hey, Gerber Life lost on this case this year. Do you agree that the risk is X, which is $150,000 in premium, paying out $80,000? Nationwide Insurance says yes, it is, and they take it. So in that scenario, all I did was swapped out an insurance carrier that your employees never see, because the employees are using Cigna or the Blues as their network. Their plan design hasn't changed, but now I've completely eliminated that cost increase. In the fully insured world, it doesn't happen that way. In the fully insured world, you have the same components. You have a network, claims administrator, which is the TPA, which is blended with the network, and a stop-loss insurance that Blue Cross Blue Shield in most cases does not own. UHC, Blue Cross, and Cigna do not own their own stop-loss carriers. Now, there are exceptions. Highmark in PA has HM Insurance out of Connecticut. Anthem Blue Cross does have an Anthem wing, but in reality, those are separate companies that they buy off of, okay? So when you're in the fully insured world, if you had that scenario, you basically would have a premium that you'd be paying in your fully insured premium. Let's assume they rated it the same way. They had a $30,000 pooling point, so they call it. They charged you $150,000, but they paid out $1 million. You guys know through experience what's going to happen. The carrier is going to say, let's say it's Blue Cross. Blue Cross is going to say, my stop loss carrier took it on the chin. I need to get their money back. And they charge you a 50, 60% renewal. Now you have a 60% renewal on something that you paid for. You paid a premium to transfer that risk for a year. You're paying for it the next year when that risk is gone, and you're paying it in perpetuity. And that's at page 5 of the sheet. If you want to use page 5, this is kind of what it is. It's an unsustainable path. It keeps going up. And the fact is, in our scenario, we can eliminate that. So you had that bad year, that high claim, you paid up to 30 grand, but the next year, that 30 grand claim is eliminated, and you're not paying for it in your insurance components. So that's one of the things that we do, and that's really normalization. We call it high claims normalization, but we can show you how it works. It's a very powerful tool that you can't get in fully insured because A, you don't have the data, number 2, you don't have the control.
So with that, I want to give you some MCT exact, numbers and experience. So in 2017, we finished up the year. It might have been U.S. Healthcare was our carrier. That was the model. We had the broker carrier model. And we ended the year, our cost was about, for 80 employees, our cost was approximately $615,000. And we were told, hey, you're going to get a 10% increase, and we're going to go to 676. At that point, that's when Mike here had introduced me to Andus, and in talking to Andus and understanding how that works, first Andus kind of had a projection without any history of MCT and the persons working there. It's hard to get an estimate of what the claims would be right out of the gate, but looking at where our pricing was with the insurance carrier already, they estimated, hey, we'd probably be around $650, $675 in terms of our overall cost to do this partial self-insuring, which would almost be about the same as if I stayed with the carrier. However, by doing this model, I could see down the road that I can control things better. So we switched. And at the end of 2018, my actual costs were $690,000, not the $650 to $675 that was estimated. And again, I would even say guesstimated, because Andus didn't have real health data on us, because when your company's less than 100 employees, they're not able to grab that data from the Blue Crosses or the U.S. Healthcares or whatever. Over 100 they can. So anyway, last year we ran $690,000 in costs, and in addition to that,
net cost is $690.
Net cost of everything. Yes,
your gross was what's higher.
Net of everything. So it's the cost of having the stop loss carrier. It's the cost of renting the network. It's the cost of the third party. And it even includes, I think, the cost of your consulting rate. So then, what happened over last year? Well, last year we had three persons who had claims over $50,000. So MCT was responsible for the first 50. After that, the stop loss carrier picked up the rest. Unfortunately, one of our employees ran up. They were really sick. So their claims hit almost $600,000. So MCT picked up the 50. Thankfully, with stop loss, that's all we had to cover. And then the stop loss carrier picked up the rest. And I want to just add that we also, in addition to stop loss on individual, you get stop loss on company. So if 10 people run into this issue, you don't get $500,000 hit. You limit it to 250. So you can buy stop loss as a group as well, which we have. But because of that huge claim year we had last year, my projected, if I were in the carrier world, my projected insurance for 2019 would have been over $960,000. So because of the high claims we had. Fortunately, because we're in this model, our estimated cost for this year was roughly about $660,000. That's the estimated cost for this year, because we did not get an increase from our stop loss insurer, basically because of the example that Brian had used. So with the huge claim number of dollars we had, our costs were in control.
You also didn't have to make any plan design changes. You didn't have to change anything. You were able to do a passive enrollment.
Right. Now, I also, just as a point of fact, that if we had additional persons that used more of the insurance, I have a max, because the stop loss on the individual and the stop loss as a group, my max would have been $800,000 that MCT would have had to have paid, versus the $676 quoted with the insurance carrier versus the $661 that I actually paid. So now we roll forward into 2019, and projected was in the beginning of the year was $660, and unfortunately, I'm the biggest user this year. I got diagnosed with a type of cancer, so I've been running up all the bills for the company, unfortunately. And but we didn't know that at time of I didn't know I was going to be sick. So, but my bills are rolling up, and we're halfway through the year, and my new projection is really right around 670 or so, 675, with a max out of pocket of like 900. About 900,000 would be my max, but right now, halfway through the year, and I'm at 660, and all those big hits were taken in the beginning of the year. So
What your projection is for, so your year to date projection, you're not 660 yet. Your year to date where you'll finish will be 675, about there. And we already have your renewal forecast right now for 12/1, forecasting you about 700,000.
Okay. So the interesting thing about all that is, so with all that, there's a lot of things that go on with self-insuring. My own experience, a couple of things. We talk about controlling the costs. Brian talks about design plan. So little things like, hey, you have to use prescription meds to get the mail order meds to get the cheapest stuff sent to you, and it's $10 a month. And I'm like, well, I like going to my local pharmacy. Can't I get those same generic meds that I get in the mail? Can I pick them up for the same price? And the answer is, yeah, we can just change the plan, and it's within the stop loss carrier's purview, and they're fine with that. So it allowed me to just go to my local pharmacy instead of having mail order. Although mail order is nice, but I like supporting local. Other things, ER visits. If you think there's too many ER visits, you incent for urgent care to, hey, you want to get a foot X-ray? Don't go to the ER. Go to urgent care for $100 instead of ER for $500, $600, $700 or whatever. Those are some of the things. Brian mentioned, do you want to have your copay for a specialist to be $50 for the employee, or $10 or $30? You can customize that. Do you want your employees to have easier access to certain benefits? You can make it cheaper. You can make it more expensive if you don't want them to use it.
And the most important part is you can get the cost. So if you're going to make a plan design change, I can show you with your data. At least I need 6 months of data, but once you're in the program, I can show you what that cost impact will be based upon your utilization and based on what that setting costs. So it's no guessing anymore. We have enough of the information in front of us to do that.
And the other thing about control, which is really interesting also, is last minute, with my issue, all of a sudden they said, hey, we're switching treatment, and they're like, you're going on immunotherapy, and I had to they're like, you got to get that approved, and I said, well, all right, well, and I wanted to, we were scheduled to get it like the next day, and like, well, you'll never get that done. It'll take like weeks. I called Brian. Brian looked up with the insurance carrier and everything, like, hey, is this approved? Is the immunotherapy that I'm getting approved? I forget some of the other things you checked, but basically I'm able to go to Brian, who can talk to, with Andus. He knows the stop loss carrier. He knows the third party administrator. So I'm not going through the big carrier and trying to work my way through that system. I'll say, call it backdooring the system. I got approved within like 2 hours just because we were waiting for phone calls back and forth. And at the hospital, the doctor's like, we've never seen that ever happen before. So you can control a lot of things that may be important to you as a company. The other thing too, hey, if I have all these issues now, what if it rolls into next year? I'm going to rack up all these bills. Will the insurance carrier target me? And they call that lasering. Do they laser in on me and say, hey, you're not 50,000 deductible anymore. You've got these issues. You're 200,000. I have the ability, if I want to, I could actually get off of the MCT plan and go on the public exchange and get the premium plan offered in my area in Philly. It's Blue Cross Gold, which is just as good as the plan we have. The whole thing would have been $25,000 for the year for a family of 4, and if I'm rated, I could rack up 200,000 of MCT bills. So it makes sense for me to be able to just get off the plan and go that way if I want. So it keeps it cheaper for the plan and cheaper for the company. So you have this flexibility if you want to do that.
In that scenario, it's really something we give you enough time to plan. The biggest thing is, rather than making your decision for a 12/1, let's say Halloween, you're making decisions for a 12/1 now.
Right.
So the renewal that I have in front of me right now is where I already have your insurance renewed. I know if there's potential lasers. I know where you're running. I have 2 years data. We can forecast with very good accuracy. We can use our statistics, our Millman tables around, also in our actuaries to forecast. So we can give you complete control. I can't prevent claims. I can't stop claims. I can't tell you who's going to have claims. I don't have the magic ball. I also can't stop it with wellness programs and all these other nonsense that you hear about. What I can give you is I can give you the numbers. I can allow you to make decisions in an informed time period.
So with that, I kind of want to turn it over to Mike Brooks because Mike's seen it from a different angle. My experience as a user and MCT's experience, this is really positive. And again, as everyone knows, after salaries, your healthcare costs are probably your number 2 costs in the company. This has worked out very well for us from a control standpoint. I'm not, I didn't save hundreds of thousands one year to the next, but I've saved what potentially would be a couple $100,000 if I had stayed on the other plan with the high expenses we incurred last year and the high expenses we're going to incur this year because of me. But Mike has a different point of view as a broker, and he's got a couple companies too. So I wanted to turn that over, and then Mike also wanted to talk about just when you talk to companies buy-in, who is the right person to talk to push this as owners, HR, that type of thing.
Okay, thanks, Bill. As Bill was saying, and Brian kind of talked about it, is I am that independent insurance agent. So I'm the broker. I've been in the business since 1985. I've been doing group health insurance since 1995, and I did the same thing. I went to the carriers. I waited for the renewal to come out within 60 days. I would go to Blue Cross, Aetna, or United Healthcare, or Oxford and get quotes, and then we would kind of go back and forth. Finally, I had one company. I did refer Brian. I actually met Brian the same time Bill did, so we kind of got experience, and my jaw dropped a little bit when I realized that there were so many different options out there, or not so many, but different options for companies to control their costs. So I think anybody listening right now, it might seem very overwhelming or confusing, and the first time you hear it, it is, but it really isn't. When you look at it, it's really, you get a third-party administrator, you have stop-loss insurance, and you buy a network. When you go directly fully insured, they all put it together, but you have no idea what your increases are. And so when I brought Brian into Bill, I had another group that I brought him to, and they had Blue Cross. It was a 55-person group. They were up to $800,000 in premium, counting their families. It went up to $880 on the renewal. So you're looking at $880,000. I brought Brian in, and they actually projected to save about $150,000. We had such a good year, they ended up saving $270,000. So you can save a lot of money, but I think the real important part is to try to keep your coverages stable. Every year I would do the same thing. I would do open enrollment. The employees would hear from me saying, I'm going to raise deductibles, change co-pays. So now for 2 years now, we've kept it steady. The owners of the company have benefited from the savings, but the HR person has benefited from the stability of the coverages. I am an independent broker. Not everybody, I bring Brian into smaller groups. I do fully insured. But any group over probably 30 to 35, I'm bringing Brian in just to analyze it. And I think that's all you should try to do is to think about bringing Brian in to really look at your data and see if he can come up with a solution, because it's really about stability.
And I think the biggest point I'll add to this, I'm no creative genius. These are the ideas that I took from working with the 10,000 life companies. This is what they do. It's risk pool management. They have enough unhealthy people being subsidized by healthy. They use stats to predict how many high claims they should have, what level of insurance they should buy. I just brought it when we started the company, brought that experience that I learned from very smart people to the small market.
And so, one of the things, and just, when I took our healthcare from the carrier model to this, I basically did it, sort of on the side with my regular job. It really, the heavy lifting is done by Andus. So it's not onerous. I mean, sometimes there's pushback, where, people don't want to take the time and effort. And, really, this really has to go to, the owners of companies to, where it hits the bottom line. They must be the champion of it. They can't just delegate and say, hey, HR, go do it, because the HR person is going to look at it. They may be saying, hey, if I do this, my friend who's the broker may not, they'll be pissed at me. They may, have different reasons for not wanting to do it. But really, it's all about controlling costs. And again, I don't know if it's as obvious to you as to me, but this is just like going from best efforts to mandatory, and we're hedging, to help you minimize that volatility to, make that profit. So to me, this just looked just like our model, but in health. So we've spoken for about 30, 35 minutes, and you guys have been graciously listening. I'd like to put out questions to the audience that you can all type in, and we can answer as we go. If you have important questions that you'd like us to ask, hey, what about, I've heard questions like, well, we have some real sick employees. They have real expensive medicines. How do you handle that? Because we're already paying through the nose there. Brian actually has some interesting info about that he's going to tell me about too at the same time. But how now, from a pharmacy standpoint, they're getting pharmaceuticals from Canada, which, as everyone living in the U.S. knows, it's a lot cheaper there. So just kind of interesting, some of that information. So I'm going to try to get to every question that's you guys have, and we'll go from there. So I'm just going to try to work this to read this, because for some reason it's not as big as I would like it, and to see the question who asked it. So I think the first question I see is, God, all right, bear with me one second, because I'm just having a problem opening up this box to see the question a little bit better. Oh, how do you incorporate a captive insurance company in your model?
All right, so captive insurance works for insurance. I'm going to keep a real simple answer. When you're buying insurance products like liability, property, and casualty, I would absolutely buy through a captive. You're buying through one insurance company, and you're getting economy of scale by buying a whole bunch of groups together. Benefits, in my opinion, and I can prove this if you give me some time. I don't have time on the webinar for it. A captive is the worst thing you can do for a health benefit program. And the reason why is you're basically going to that bundled scenario where you're all buying into one stop loss carrier. Remember, the insurance component is a small component. That's the part you're buying to eliminate volatility. Why are you then giving that stop loss carrier complete control to determine what you should offer, what network, what you offer, how to set up your plan design, all those scenarios? So I can tell you over time what happens is a benefit captive starts, everybody loves it because they get economies of scale, everybody's a good risk because the risk pool is good. Eventually, the really good risks subsidize the unhealthy risk. And 1 year you can be a real unhealthy group, the next year you're healthy. Well, what happens is the healthy group realizes they're basically subsidizing the unhealthy group down the street. They get pulled out by smart brokers like Mike, okay, that pull them out and send them to me, and eventually you're left with just what I call the toilet bowl. That's a very quick answer, but if that person has answers, please send me. I can walk you through a little bit more about how captives will not work for you in the long run. You'd rather control your own risk pool, control what you buy on each component. As Bill says, look under the hood and buy everything more efficiently.
But you could use your captive to pay your insurance losses, right?
Absolutely. So a captive is very different for insurance. So there's different scenarios for those, but a captive program that people buy for the benefits is not a good idea.
Another question: to make sense financially, is there a minimum number of participants that you'd recommend under this model?
Yeah. So one of the things I'm always going to do, we are paid as an advisor. We are not compensated. So we're agnostic on carriers. We are not paid by the carrier. So I will always give you the best advice. There are some groups where it may not make sense. What I mean by that, if you're a group of 11 to 15 people and you're all age 60, I will tell you, and you don't have any dependents, I will tell you stay on, even though the demographic rates that you're getting on the fully insured are outlandish, you're probably better off staying that way. However, almost all groups can benefit from this because people will always tell me, my group's sick or my group's old. Well, yes, you may have employees that are 50 years old and you may only have them on a plan. But here's the best part. If you got their 26-year-old kids on the plan or their 18-year-old sons and daughters on the plan, your risk pool just got younger. And you can benefit from the contributions that will come from that group and the larger risk pool and the economies of scale. So to answer your question, we really can't do much below 10 10 is our minimum. Usually 10 to 25, though, is an area where I probably most of the time will advise against doing this, but I do have quite a few groups in that size. Anybody over 25 should absolutely evaluate this, and anybody over 50 eligible, not 50 employees, 50 eligible, who is absolutely experience rated, here's the best news. You're already partially self-insured. If you're over 50, you don't know it because you're under this fully insured model, but you're rated on experience and you have all the components of a partial self-insured. So anybody over 50 should never be fully insured, ever. And that's my true opinion.
All right, let's get to the next one. Hang on one second. All right, so next question. Having some technical difficulties opening this model. Between the claims administrator, the cost to rent the network, and the stop-loss insurance, which cost is subject to the most volatility?
So administration of the network is flat. I can buy from most of my third-party administrators, and you'll never pay. If you get increases, it's once every 3 years at a 2% clip. Your stop-loss, because of leverage trend, if you keep your stop-loss at the same level, you can experience a small increase, 5% every year in the insurance component. But that's also very easy to get around. So volatility, as far as your fixed costs, should be very minimal. Your volatility is really your claims expectation, right? And Bill referred to possible lasers. So if I know that somebody's going to cost 120 grand, I know it's because somebody's spending $10,000 a month on RX. If I went to an insurance carrier and said, hey, why don't you insure this person at a $50,000 spec, meaning the insurance carrier is guaranteed to pay $70,000. Do you think that the insurance carrier is going to give me dollar for dollar? No, they're going to charge $70,000 plus a 50% margin. So in that scenario, I would advise my client to say, why don't we assume that 120,000? Let's put insurance caps on that individual at 120, thus called a laser, and let's keep our fixed cost low for everybody else. So in reality, the only volatility is your claims. I can basically, after a year or two, I know how to bracket that with the right insurance products to protect you so that your cash flow can't go off the charts. Number two, when we're building your accruals, your funding for these plans, we're usually building the funding towards the max. So we should be able to build reserves so that you can handle the rainy day volatility. Here's the best answer for you. Over a 5-year period, you're going to have 2 bad years and 2 good years and 1 year in the middle. That's average. However, have I seen groups that have 3 bad years in a row? Sure have. Those are my best clients. The clients that go through the bad years are my best clients. Those are the ones that I give you as a reference will tell you, hey, I see how it works on a bad year. On a good year, that's great, we save money. But the bad years is where it really shows the value because we didn't go on that scale going up every year.
Right. But can you give I know it's pretty fixed, the administrator, like a per person fee for the third party administrator. Was it like $10 or 15?
It depends on what you use. So if I use United Healthcare, which I can only use for groups over 100 lives, their fixed costs are the lowest, so it's $38 per employee per month.
And that's to use their network.
Yeah, you pay claims. Your Blue Cross Blue Shield's average across the country. Anthem's a little bit more expensive than Philly. Care First cheaper in Baltimore. So average out around $41. Your Cigna third-party administrators are usually around $45 to $48, depending on the size of the group. And then there's some carriers that'll charge $50. It really depends on who you're buying, but your average administrative costs are around the $40 to $50 mark.
So 40 or 50
per employee per month
to rent the network.
Correct.
Then to use the third-party administrator.
That's included in that.
Oh, I thought I see a separate.
Right.
So
50
your
stop loss is your separate component.
Okay.
Mm-hmm.
All right, good. So, hey, somebody asked a question, hey, do you have contact info? So I just put it up on the screen. We can also email it out to everybody that listened to the webinar, but, Brian's info, he's here.
That's my cell phone, too, so please call me anytime. You'll find out that I have an 8-year-old son, 7-year-old, and a 5-year-old. So if you call me at 7 o'clock, I might have to tell you I have to put the kids to bed for the next hour because they don't go to bed right away. But after that, I'm always available. So call me anytime.
But he will answer the phone and tell you that, though.
Yes, I will.
So, he's, available all the time. And there's obviously a whole company behind Brian that we work with. But, for these, sometimes you guys have some real specific questions that are unique to you. And Brian's, just the dead-on expert for all of this. But so here, his website is
You can see the team on the website too.
Yeah,
You'll
and
see all of our team members on there.
I'll bring the website up in a second. So, but there's a website, and there's a lot of good videos on his website as well. So, if you go there, and I'm just bringing it up now, hopefully here, and hopefully you can see it. But on the website there, you'll see his videos and more information. But I'm going to try to go to the next question. What percentage of small to mid-sized businesses use the self-insured model now, and is it growing?
So the answer to that question, when I worked for a large company, when I used to work with the Fortune 500s, the Midwest has the largest. Everybody's basically partially self-insured in the Midwest. They'll throw brokers out of the office if a broker says anything about fully insured. So in the Midwest, you have groups insuring at 50 lives, and we have quite a few clients in the Midwest: Ohio, Indiana, Illinois. On the East Coast and West Coast, it's a lot less. It's more fully insured. The brokers control the markets. So I will tell you, any group over 50 lives should absolutely be partially self-insured. If anybody's calling here from the Midwest, which I'm assuming they are, call your neighbors, and I bet you they're going to tell you, yeah, we're partially self-insured. So there's really, the percentage across the country, I couldn't tell you because it's not something that would be relevant to what I do. But I can tell you it's a growing model. Unfortunately, it's growing because the brokers are selling the wrong products. They're selling level funded products and captives. So it's growing, but it's also not getting the best bang for the buck like it would in an open architecture solution that we're talking about.
So here's the next question. This is a really good question. And I'll give you a little bit of an answer how I did it, and then, with Andus's guidance, but, and then Brian can jump in. But how do you determine employee deduction amounts, and do these deductions go into a pool of the company that we then put towards claims versus paying a bill from the carrier? So, when we switched to this model, we didn't want to rock everyone's world and have their health, what they normally were paying and doing turn upside down and look totally different. So we did follow the deductibles and tried to follow what the prior the carrier was offering. So it could be, for employees, it could be, they have to contribute 20% of the overall premium per person per month. MCT contributes 80%. So that 20% gets pulled and goes into that's pulled and goes into our pool along with the premium we pay. And then as far as like deductibles and stuff, there's different plans where you have a $250,000 and out-of-pocket max of $5,000. So when that happens, with the deductibles, and Brian, correct me if I'm wrong, that's where the employee is actually paying the doctor.
That's what I call member burdens. That's deciding what the employee pays when they access care. The question they're asking is about the contribution. So to answer your question, when you guys built the plan, we kept your plans the same way they were.
Mm-hmm.
We just matched them. We could have made tweaks. We talked about it. You guys chose not to, and it's good. You kept everything simple. We kept your contribution the same as it is. And under ERISA, you have the fiduciary responsibility of making sure if you're collecting those contributions, you still have the same scenario where you have to make sure they go towards the plan. So nothing changes. We help you build those premium equivalencies so you can decide how much you are paying as an employer and how much of that can be paid by the employee. And 99 out of 100 times, we're going to tell you to keep the employee contribution where it is. And there's a couple reasons for that. One, you're going to why not make it stable for your employees? Number two, there's really three. Number two, the ACA guidelines on the 9.6% on the lowest plan on a single. But the third reason is really keeping your risk pool intact. I'm going to show you why you want to have kids on the plan. I'm going to show you why every kid that comes on the plan is going to give you more dollars towards your plan because the risk they have for claims is so much lower. And I'll show you how you'll be able to build your contribution strategy up while making your employees happy because now they can affordably put their kids on the plan. Most employers go the opposite way, thus making adverse selection and their risk pools worse.
Right, absolutely. So yeah, the healthier people in it supports the pool. Mm-hmm. Here's another great question. How well does this model work for larger groups, 100, 180 to 200 range? I mean, the MCT model, we're I think 79 employees that are insured.
It works the best for groups over 100. So here's why. There's two things. Bill had talked about me guessing. When I go to a group that's 50 to 75, 50 to 100, I'm good at guessing. It's still a guesstimate, but I'm good at it because I can take your demographics, where you're located, your premiums, and I can try to guess pretty much using enough trust me, we've got actuaries on staff that can kind of run this and say, here's where we believe you'll be. But because we're on the data, we're still guessing. Groups over 100 should absolutely be doing this because you already have the data. So now I'm not guessing. I take your data and I put it in a format and say, okay.
And it's the health claims data.
It's the health claims data,
Okay.
yeah. And you get the benefits of fixed costs. So any group over 100, this is really simple, but it's also simple from 50 to 100. We found our niche to be 50 to 100. My experience for 15 years was running 1,000 life, 200 life, 10,000 life companies. So I've gotten in over the past 5 years with this company, working with the groups 50 to 100, which is just the niche that we found. But we have quite a few. We have our largest clients, 100,000 employees. Our average client is 90 employees. But we have quite a few clients we have retailers. Mike and I have a large restaurant group based out of Philadelphia, big name. I won't mention them, but a big name that we have that has 200 employees. So.
Another really good question. Is this only for medical, or can you include supplemental like dental, vision, life, et cetera?
So I can easily self-insure dental and should absolutely do it. Medical is the only place I have a real trick, right? And I call it trick, but it's no secret. Anybody should be doing this. I did not invent this. This has been done forever by the smartest people for the largest companies. For medical, it works very well. For dental, it works as well because dental has a cap on it at $1,000 per utilization. So ASO dental or self-insured dental is a great product. I have no trick for life insurance, long-term disability. Short-term I do, but life insurance and long-term disability really has to do with what is your risk of getting injured, how long you expect to live after you hit 42. Those are true broker commodity prices that we do because we can still broker them, but we have no trick to the trade for those.
Interesting. All right. Keep going here. This is a good question. And this is really kind of interesting. Do you have any clients with multiple networks like Anthem and Kaiser? And you know what's interesting with MCT, we're national, right? You know, there's 10 of us in Philadelphia. We have a large group in California. We have another group in Dallas, Texas, and then we have some sales folks scattered throughout the country. So we are, you know, all over, if you will. And Kaiser is huge in California. So Brian, I'll let you.
Well, we consolidated everything under one network for most groups, and the reason we do that is sometimes people have loyalty to networks, but they don't really understand. So the networks have convinced them that they're the only game in town. There's a lot of national networks. Unfortunately, for groups under 100, you can't buy. The Blues keep their top line revenue. So even though they're supposedly nonprofits, some of them are for-profits like Anthem, but they will not allow you to do this on their network. They make you have a 100 requirement. Cigna and Aetna will play in these markets, and Cigna and Aetna have great access across the country. And the truth is, in the end, when you realize that all doctors accept these networks, you can usually buy one network. It rarely makes sense to have two networks, and this is for one reason. There's one simple reason for that. You're paying two administrative costs for two smaller groups. So you don't get the economies of scale of combining them.
Right.
I have no problem if you want to do that for some reasons that are specific, but most of the time I'll be able to advise you out of doing that. But once again, we are agnostic. I don't care what carrier you use.
But at MCT, we were concerned because we had, let's say it was U.S. Healthcare and Kaiser, because Kaiser's big in California.
Yep. And they're big in D.C.
And we were really concerned that, hey, if we eliminated Kaiser, there's only doctors that will work with Kaiser.
Yep.
Now, we, you know, from an insurance point of view and from a doctor point of view, we have not had an issue in 2 years that, hey, this doctor is Kaiser only and it's not going to work.
Because they have reciprocity agreements. That's the thing. They'll convince you. There's a lot of misinformation out there. And unfortunately, the brokers are paid by the carriers, so they'll give you that misinformation. The first thing we would do if we're ever looking at network, we would do a network match. We go all the way down to if you give me the doctors you're on, and if you have the data, if you're over 100, you may have it. We can show you that a network switch would not create any issues. And in many cases, especially if you're over 100, we don't have to switch your networks.
Right.
So, like I said, I'm agnostic on the carrier you use.
Here's another good question. What kind of time is required on the company side for managing this process? Does it require a full-time employee to manage the process and payments? So again, I'll give you my experience. Again, I brought us, you know, over from our carrier model, which I wasn't involved in, to this model with Andus. And, you know, sort of like I did it on the side, if you will. It really wasn't, you know, a lot of paperwork going back and forth between Andus and myself, making sure things got signed, a lot of I dotting and T crossing. But Andus was doing the heavy lifting. And we talk about requiring full-time employee to manage the process of payments. So our controller, the way it works, our controller, with the third-party administrator, they would send me a bill that says, hey, here are your claims that have to be paid this week. And you can review the claims, and then I pass it on to the controller saying okay to pay, and then the controller puts that amount into I'm going to do it in adjusted, but a joint bank account, if you will, with the third party administrator and MCT. So we put the money in, they pull it out and pay the claim. So the beauty is the third party administrator is doing all that detailed work. They're telling me in summary, here's the all-in dollar you need to put in so we can pull out and pay those claims.
And then we're making sure we're reviewing the claims every week to make sure the stop loss is applied properly. So the answer to this question is it's no different, except that instead of getting a bill once a month, you're now getting a claims bill every week and a fixed cost bill every month. But we manage this for you. But yes, I will tell you, is it as simple as fully insured? No, fully insured is easy. Just pay the 20% increase every year and pay the premium. Pay your premium every month, and that's it. That's how easy.
My experience was the initial setup was a little more work, but it wasn't too overwhelming. And then the one company that I used to save the money, the HR person does it, and she says she loves it. It's no different than the fully insured. So
there's some
too much work.
There's some HIPAA things we got to make sure you're aware of because you'll see claims data, things like that. But we handle all that for you. But yes, I will tell you it is more work, but limited. But it's more work, but you're not hiring a fully insured. You just need to use our guidance, and we can set that properly.
One or two other things I just wanted to talk about was one was state laws. I remember talking. We have clients in Jersey, and they had some tough state insurance laws. But this model, you says...
Yes, so New Jersey, Connecticut, Rhode Island, New York, have a lot, Maryland included, have a lot of state mandates. A lot of those state mandates really create huge costs. And there are things that a lot of times employers don't want to cover, but they're forced to under fully insured. Under self-insured, partial self-insured, you only have to cover ERISA and ACA guidelines. So you have to cover all the ACA guidelines for benefits, the out-of-pocket maximums, things like that. And you have to cover any ERISA guidelines, such as Mental Health Parity Act and federal guidelines. But you don't have to cover bariatric surgery if you don't want to. You don't have to cover infertility. Now, you have a choice. You can, and I have employers that choose to. But I can show you why eliminating those costs can work for you, or capping those costs. So we can always work with anybody to say, here's the state mandates. What do you want to include? What don't you? And we manage that from a compliance standpoint.
Okay. Another question that I had was ADP.
Mm-hmm.
So one of our clients, there's an MCT client that is using Andus as well. Smaller client, and they were using ADP, and ADP is telling them we can do everything for you. We're going to do your payroll, we're doing your health benefits. They probably do the 401k. And I just thought maybe you could just talk about the ADP.
It's just inefficient. I mean, in the long run, you're paying a huge margin on your benefit piece for something they shouldn't be managing. ADP is some people argue, I believe one of the best payroll companies because they're so robust. They have the best technology. If I wanted to buy an HRIS system or a payroll system, I'm going to ADP or Paychex. I'm not having them price or broker my medical insurance because I know they're going to put a load on top of it, and I know they're making money, and they're going to give me zero control. So people get caught up in that whole thing of saying, I need to have all this. Well, you can still have all those other products without buying benefits from ADP.
Okay. So, it looks like that's the end of the questions that are being put in there. As far as I can see, if there's other questions, please let me know. The beauty of this model is control, just like in hedging. I think you're controlling your environment. You control what you want to do, and it's not a short-term type of win. These aren't short-term. This is the long-term, so we don't have these ridiculous premiums down the road that just keep on going up and skyrocketing. So again, just like hedging, hey, you got to have a 3-month look or longer just to see if it's working. This is a couple of years in a row, because as in the MCT example, had I been on the other model with all the claims last year, close to $1 million, and then the more claims this year, I'd be even higher. But instead, we're staying the same because of the control we have, and we're able to isolate different things and manage it better. So With that, I really want to thank Mike Brooks, who introduced me to Brian, and then also thank Brian for coming in and talking as well. I think this is a really interesting business model. I think it makes a lot of sense, and you know, we're just thrilled with the information and how it's working. And for those that are going to be attending our conference in September, Brian's going to be there if you want to meet him, if you have more questions you want to ask about him. In addition, up on the screen, I do have his information again. So if you, you know, want to reach out, you can just let him know, hey, you're on the webinar, however you heard about it, whatever, and I'm sure he'll be happy to help you. So again, thanks everyone for attending, and hopefully you found this informative. With that, I'm going to sign off.